Let's talk about sort of risk stratification, Matt. There's a bunch of different scales that you can use. The Flippy 2. I mean, do you use these? Is it just for research? Does it help you in any way?
Yeah, so I go back to thinking about the mannequins for the Flippy and counting nodal stations, which as a fellow, it was a project that you often got to do, and you had to add them up and figure out what their Flippy score is or their Flippy 2 score. And then coming along as we ventured further and further into the rituximab era, the M7 Flippy. But the M7 Flippy incorporates some tests that may not be available to everybody. So the utility of that kind of stepping back, while it was interesting data and kind of in some ways created some controversy around the Flippy and the Flippy 2, I just don't know how applicable the M7 Flippy is. I put it down because I was once doing retrospective studies, and so you're trying to help the next person going through to say, okay, this was their Flippy score at diagnosis, so somebody else isn't having to scour through documents to do it. Do it once, do it right. But to say that it affects how if I'm gonna treat a patient versus active surveillance or guiding me along as a risk adaptation strategy, it's not to date. So.
I think one of the challenges is that people confuse the Flippy with the need to treat. And that's something just to look out for, in the sense that somebody can have a very high Flippy, but if they're asymptomatic, there's still no indication to expose them to treatment that so far hasn't shown to cure anyone or extend their life.
Right. And I think, Sonny, with and what we're talking about, I think exposure is one of the, I think is the probably main weakness within these scoring systems, is that it doesn't predict individual patient risk, right? It predicts the group's risk. But there are many patients, as you mentioned, that have high-risk Flippy scores. They have very low volume disease and may do very, very well. And there are patients with very low-risk Flippy scores that sometimes do poorly. So, using it to stratify treatment is I think, pretty difficult.
Yeah.
On the flip side, not to pardon the pun, I think that the patients that are high-risk Flippy patients are the ones that tend to have more disease, tend to have more symptoms, maybe anemic. And so, I think that at the end of the day, I agree with you that if a patient has high-risk Flippy and still feels fine and doesn't have indications for treatment, it's fine not to treat them. But when you look at kind of the Venn diagram, a larger proportion of higher-risk Flippy patients are going to have an indication for treatment than the lower-risk Flippy patients will.
Do you give a different therapy? Do you give R-CHOP versus bendamustine, or does it make any difference to you?
I would say that it doesn't strictly make a difference, but I think that, again, remembering that number of sites of disease and LDH fall into the Flippy category, and so many of those patients will have bulkier disease. That's where I'm at least looking more closely. I mean, you have to figure that the high-risk Flippy group, if any of the groups has a possibility of kind of occult transformation, that's going to be the group that has it. So I would tend to look a little harder for transformation, or think a little harder for transformation in that group. And if I found it, obviously, I'd give R-CHOP.
So, Sonny, you mentioned that that the Flippy wasn't necessarily an indication for treatment. So what are the indications for treatment? We have the GELF criteria. What drives you to want to treat somebody?
Yeah, I think the key thing to remember is that this is a disease that to date we can't cure. And if the goal of treatment is essentially palliation and trying to give people a deep remission that lasts, I think that's one goal of therapy. And so until they have symptoms, I have nothing to palliate. So I wait until they have symptoms. The GELF criteria, and there's also BNLI criteria, and NCCN has their criteria, but they all fall along the same lines, which is, if there's cytopenias due to disease, if there's effusions due to disease, or other B symptoms related to the lymphoma, then you're justified in starting some type of therapy. Now, there are times when people don't meet those GELF criteria that I will think about therapy, and sometimes that's very patient-driven. Either they feel extremely uncomfortable with the observational approach. Active observation is the term I'm using now instead of watch and wait. I think active surveillance and active observation sounds better. And for those patients, I think there is still a need to, kind of take care of the whole patient. And so if they do want something, I'm trying to find something low intensity. But you know, for most patients, I wait until they have some type of GELF criteria, which is symptoms, effusions, or cytopenias.